in a room where many people think of themselves, either rightly or wrongly, as pioneers, as giants upon a stage, there are actually a few people like that. And one of them is our next speaker. I think that anybody who doesn't know who Carl Bakr is in the world of diabetic foot care has been asleep or living under a rock or something. Carl is one of the real giants in this field. He has been a great teacher, a great researcher. He carries the message forward, and besides which, he's a very dear friend. So it gives me great, great pleasure to introduce to you our next and final speaker for the morning session, Dr. Carl Bakr, who will talk about the International Working Group on the Diabetic Foot, stepping up or walking in place. Carl.
Thank you very much, George, for this very kind introduction. This session is called The Diabetic Foot in Global Relief, Views from the 30,000 Feet and Up from the Soul, just to remember. But my talk should go about the IWDF stepping up or walking down. Many years ago, there was already diagnosed diabetes, 1550 years before Christ. And now we still deal with diabetes. We have even 400 million people with diabetes, and it's going up and up. This is the first papyrus reference for diabetes, as described in the Lancet. Up from the soul, I like to go back what we have done as International Working Group on the Diabetic Foot and other organizations till 2014. We organized the World Diabetes Day, which we turned in a year of diabetes foot care, in 2005, together with the World Health Organization and the IDF. The primary global awareness campaign of the diabetes world, celebrated worldwide by IDF member associations, hospitals and clinics, World Health Organization collaboration centers, etc. That year, we gave press conferences, TV interviews in every region, which means in every continent. There were that year 20 foot congresses all over the world. You have to realize that's 20 years ago. And according to the IDF, that year we have reached 500 million people in our awareness campaign. Can we go back now to the full slide? So this is what many people remember, the leaflet and poster in French, Spanish and English we made public, and that was a major part of our awareness campaign. Also what happened was the development of step-by-step projects. I'm pleased to hear and to know that this program is nowadays very popular. But I'd like to go back to Dar es Salaam, Tanzania, where Dr. Abbas showed the World Diabetes Foundation board his foot clinic. And of course they turned us down a year before when we designed the step-by-step project. They were so impressed what they saw in negative way that instead of being there for only 30 minutes, they stayed there 2.5 hours. And they said, Carl, please come back and apply again for a grant. And that's what we did. We designed a step-by-step project, and this is the historic picture. In India, we had this meeting, and you see the late Ali Foster at the left, your speaker, but also Dr. Abbas, Dr. Pense, Dr. Viswanathan, and 2 members from the World Diabetes Foundation management. And that is the moment when we start to develop these programs. Nowadays, we have these programs in almost 30 countries. And I name a few because the first two were pilot studies in India and Tanzania. And the nice thing is that Dr. Abbas in Tanzania showed that there is a significant improvement of amputation rates thanks to the step-by-step program. These publications we need to justify what we are doing. Another thing I'd like to mention that we had a 6 years program in the Caribbean thanks to a modest Rotary Club in England of Ledbury, the Rotary Club of Ledbury. They involved another 36 Rotary clubs, and they presented us in the 6 years not only with support, friendship and management, but also with almost $500,000 for these programs, together with the IDF and to a lesser extent with the World Diabetes Foundation. We were able to create step-by-step projects the first year and the second year, and the follow-up year even, in 10 countries or islands in the Caribbean. But instead of sending all these faculties, mostly from Europe or from Africa or the United States, to these countries, there was a working group who designed the new model, Train the Foot Trainer course. This course means that we train local top educators to set up the step-by-step project instead of flying every time us in to these countries or regions. And it became a very successful project. I have to remember you that we had 2 projects in. The first one was the Dhaka, December 2012, and all these 13 countries were involved in this program. And nowadays, 80% of all the countries from the Dhaka region, they have their own step-by-step program by own people, and that's a very important thing. The next one was in June 2013. 22 countries from the Caribbean area and Central America were involved in this project. Also, what we started to do was the international guidelines set up, the IWDDF guidelines. But I come back on that. It started in 1999 and is still going on. And also the support for the International Symposium on the Diabetic Foot, and that is every 4 years. Now, we have a new chair, Dr. Christine van Akker, who is a very active and engaged chair of the IWDDF and IDF consultative section on the diabetic foot. And she's here talking with Peter Kavanagh, and Peter Kavanagh was the name giver of our IWDDF. So he wrote in a paper in 1996 already, why don't we invent this name, the IWDDF? And now they are talking, and it's like Christine van Akker is asking, can I do that all? Yes, she can. Now, the title is also Views from 30,000 feet. So I'd like to go over what has been done since 2014 in a triennium that lasts till next year. And I'm very pleased to tell you that in November 2014, the first diabetic foot assistant program was held in the world in Dubai. America is blessed with 15,000 podiatrists, but 170 countries they have no podiatrists at all. So in 2009, we designed a program called the Diabetic Foot Care Assistant Program to train nurses, technicians as a first screener for foot care. And we know that it pays off. So this first meeting in Dubai was held in November. And it was a great success. This was led by Monia Sabas, a very active nurse, and also by the just founded Gulf Diabetic Foot Study Group the year before. And you see here in the middle, and as initiator with other people of this program, we felt very well that this program was performed now for the first time. Then there is an interesting new working group called FLIRT. What does that mean? FLIRT means Footwear Project for Low-Income Regions Together. Right? It's a funny name. I hope it works. Sikko Bus is here, and he's one of the leaders, and many others. As you can see, you will probably recognize Christine van Akker is there, Abbas is there, Dr. Viswanathan, Dr. Luigi Uccioli, Camillo Burato, who is sponsoring this meeting. And the idea is to create affordable and practical wearable footwear in low-income countries. And that is a very big step forward if we achieve that. So we hope that this working group is going to be very active and that they come up with results and that we can introduce in countries or regions or continents like Africa and others better foot care. It's going to save a lot of amputations. Then I talked already about the Train the Foot Trainer course, but after Brazil and the South American region and the Caribbean region and Central America region, there was just held in February this year in Bled a Train the Foot Trainer Central Europe program with 18 countries. And that is very important because, what I said, there are no podiatrists in these countries. So we have to find a way to do the first screening by people who at least know something. And that is to learn from the step-by-step program through this Train the Foot Trainer program, as I said. And you see here the faculty: Neil Baker, Wilmar Bansik, Stefan Morbach, Maureen Bates, Nina, who is here. She just talked to us. Christine, Oleg, Abbas, Martin Perry, and the Polish representative. And now I need some help, but it's not important. I'll tell you later what her name is. I forgot. Anna. Yeah. I'm sorry about that. But Anna, you are mentioned. Another initiative is the Java data collection. And that's very important because we need to be on the same line and to collect data. Dr. Lena Kleinobrai from Paris is a wonderful person, and she designed this program with some other people. And this was introduced for the first time in the Saka region, and it now becomes worldwide known, and you can read it about her activities in the latest newsletter we have published just 2 weeks ago, the March newsletter from the IWDF. Now I change the subject a little bit. In the 2005 issue, because of the World Diabetes Year on the diabetic foot, on behalf of that, there was a whole Lancet issue on foot care. And Professor Bolton was one of the co-editors, as William Jeffcourt was. And we mentioned at that time that we had every 30 seconds a lower limb lost somewhere in the world to diabetes. And we think now it is every 20 seconds. So imagine that I talk now 13 minutes, that we have lost 3 times that number of amputation in the world. So I'd like to focus on a not IWDF initiative, but a very important initiative from the ISPO. The ISPO, that is the International Society for Prosthetics and Orthotics. And is organized by orthopedic surgeons and rehabilitation specialists. And it is to provide prostheses and orthotics. And you can see that ancient Egypt were the first to know how to create a prosthesis for amputations already so many years ago, 3,500 years ago. Our chair in the right lower corner is also a bird watcher. She is looking to find something from 30,000 feet, and it's not your American eagle, although that's a very prominent bird. Sometimes you get manna from heaven, and I'd like to show you a little movie.
Niech wracają. Where are you going? Where are you going? Hello, it's Bakr speaking. Yeah, we are very busy today because we have so many people. So, a 40-year-old man, left leg, approximately 7 meters. Young man, 22, left leg, cut from
bringing used prosthetics to the places where they are needed. And I think that's what we have to remember. If we can do what the ISPO does, is sending used prosthetics I should say, to the countries where they are not available, then you do a lot. We all talked about prevention on amputation, but we cannot deny that we have many amputations. And the next step is to make them walkable again. The amputees, they will be very grateful. The last few slides handles about guidelines. As you remember, in 1999 we started to publish and to launch the first guidelines. That's a little booklet, and we had 26 translations, can you imagine, from that little booklet. And every 4 years we did the same. And now in 2005 we have new guidelines. It's called not guidelines any longer, we have called it guidance documents. The International Working Group Diabetic Food Guidance on the Management and Prevention of Food Problems in Diabetes. And you see here on the right picture the editorial board. From left, Professor Appelquist, Professor Schaper, Professor Lipsky, Dr. Jaap Nette, and the number 5 is taking the pictures, myself. All these guidance documents are based on reviews, systematic reviews. We have 45 experts in the world to fly in to work on these guidelines in 6 working groups. And we have now had already 15 meetings from more than one, mostly 2 days. And we will present and launch at the International Symposium on the Diabetic Food in The Hague in 2 months, in May, guidance documents on prevention, and some of the chairs are here. Sikko Bus is chairing this working group. Guidance on the management, prognosis and diagnosis of peripheral arterial disease and diabetes. The chair, Professor Schaper, is here. Guidance on interventions to enhance healing of foot ulcers in diabetes. Not the chair. She, Fran Game, is in Australia, but William Jeffcoat, the secretary, is here. Guidance on footwear and offloading. Interventions to prevent and heal foot ulcers in diabetes, I should say. Peter Kavanagh is not here, but Sikko Bus is the secretary, and he's here. And then at the end, the guidance and diagnosis and treatment of foot infection. And that is Ben Lipsky. So, I'd like to invite you to come to The Hague in May 20 to 23rd. Not only save the date, register. It's a fantastic symposium. We have more than 800 registers already. We expect something like 1,200 or more. We have a fantastic faculty with 40 invited speakers, 350 abstracts we have invited. We have 20 workshops. So feel welcome, and we hope to see you all there. Thank you very much.
Professor Bakr, you can spin around if you like and take your choice of seats. It's all yours and your prerogative. We have the other speakers up to the podium as well. And all of these papers are now open for discussion. And if you want to sashay up to the microphone, you're certainly welcome. We have such an awesome brain trust, to coin a phrase I learned from Professor Bolton. I did. Hyperbole.
His slides from Augusto Conte that demography is destiny, and definitively diabetes is one of the major world epidemic. But we have another world epidemic, that is aging. Our population is aging all around the world, and there are a lot of overlapping between the symptoms of aging and diabetic foot ulcer that also reflected on some of the talks actually today. For example, we hear from Dr. Schaper that 60% of patients with diabetic foot ulcer, they cannot do self-care. And loss of independence is one of the major concerns of the aging. That's one of the main reasons that lead them to the nursing home. That's very costly to healthcare. Also, frailty is another major symptom in older adults. That's very costly. And we observe in one of our ongoing study that prevalence of frailty in the patient with diabetic foot ulcer is almost 5 times higher than age-matched.
Dr. Najafi, is there a question in there somewhere?
Oh, no, there's a question. I'm hearing it now. I got 2 words.
Yes, so I'm coming back to that aspect. So my question that I would like, and I hope that Dr. Armstrong, Dr. Schaper, and Dr.
Here we go. It's coming.
Grant can address that, is that whether there is a possibility to create a coalition between the people who are caring about older adults and diabetic foot ulcer because of the huge overlapping between them, and whether for the outcomes also we should consider some of the outcomes that does matter for aging population, like frailty, like prevention of fall, and what are your advice to actually bring also gerontology as a part of the to and flow interdisciplinary collaboration.
Bijan, that was an epic Shakespearean soliloquy, but still very, very important, signifying something. To you, Professor Schaper, self-care, the elderly demography now, destiny, are we just going to be punished worldwide with all of these patients that can't care for themselves. What's the solution? Followed by Professor Bakr. You two Dutchmen are going to sort this out.
And you can't speak till tomorrow and tomorrow and tomorrow.
Oh, geez. Sure, we're going to keep going? Oh, man.
Well, I think I fully recognize the picture you draw, and we have to realize that even it goes further, that these patients have a huge incidence of falls because of the neuropathy. They have problems with walking, etc., etc. So yes, I think diabetic foot ulcer care should be part. You should, as I think our chairman already stated earlier, you should not treat the hole in the patient, but the whole patient. So yes, I think if you have a toe and flow concept, you should incorporate that in a holistic approach, where you also approach the diabetes, the immobility, the self-care problems, etc. Because to heal an ulcer in a patient who will never walk is maybe a waste of money and time.
Now, Nicholas, I have a question. You said 60% can't take care of themselves.
Yeah.
What does it mean you can't take care of yourself?
Yeah,
you can't do your dressings, you can't drive to the clinic. What does that mean?
Yeah, it was a very few simple questions, and where patients, what we call those on household activities, and then patients could not at least do 1 out of 4 household activities. Either they should have assistance with washing themselves, they should have assistance with making their dinner, things like that. So it's not that these patients are completely dependent upon others, but they are at least partly dependent upon others.
Microphone 2 here.
You've been so patient.
Thank you. Is this working? Yes, I'm Arthur Axelbank. I'm a family physician in North Carolina, and around most of the world call me a general practitioner, I guess. We trained in residency and family practice. I'm a 30-year guy. My financial disclosure is that 100% of my revenues are from patient care, about 25% Medicare, Medicaid, 50% third party, and 25% people pay out of pocket to see me. I'm just the first time attendee at this conference, and I must say I'm blown away by the top-notch quality. I do have a brief comment. It's very brief. I'm spellbound by the papers and the talks here, especially comment on the international collegiality among you all. Obviously, friendships and collegial relationships, which clearly is taking this to a great level. So my observation is that the multidisciplinary approach seems to be clearly the way to go. And I know that's in the macro with Dr. Piagetsi in Italy, but also the micro with Dr. Meyer in Philadelphia, the cloud of specialists. And I saw in here there was a general internist, but you could almost be lost in that cloud. And so my question is a clinical question. 63% of the patients are seeing a primary care physician. I didn't know if that was a high number or a low number. I guess you could see it both ways. But my question is, how do we decide on which is the appropriate patient to refer? And I think there's a cusp there. Well, I know that comment that some guys don't want to see the patient. I think the access is important for our patients. They don't always want to go to the medical center. We have a medical center in range, but they don't want to sit there all day in the clinic. That's part of the problem, or they don't have the resources to get there. How do we know which patients we should refer, which patients we should not refer? And is it different for the neuropathic patient versus the ischemic foot?
The answer to your question, and that's a superb question, is yes. Professor Bolton, the comprehensive diabetic foot exam, you want to speak to that? And who needs to get referred and not to a GP? Or from a GP to you or to the multidisciplinary team?
I think that the GP is a key member of the team. The primary care physician is the gatekeeper. And we've devised the comprehensive diabetic foot exam by the American Diabetes Association, and also the 5-minute or 3-minute foot exam. And I think if you've got an ischemic patient with rest pain, certainly they need referral. If they've got one with a claudication that's progressive, they need referral to a vascular. You've probably got district podiatry as well. A podiatrist is a key member of the team. And in UK, the primary care physician will work with a nurse educator and a podiatrist. And it's the patient with a neuropathic plantar ulcer that needs casting. You might not be able to do that. That might be one for referral. There are no strict guidelines. It depends on your level of confidence. And the fact you're here is great, because we need family physicians, and you're obviously interested. So you're probably less needing to refer patients than those primary care physicians that don't know about the diabetic foot and aren't coming here.
That
There's
being
no
said-
clear answer.
Yeah, that being said, there is, I mean, even very recently, the 3-minute exam for family physicians and mid-level providers under your aegis that I think can really guide you. And the answer is that if a person is low risk, meaning they have enough sensation to protect themselves, those people may only need to be seen once a year by a specialist, and then it goes on up from there, from neuropathy to peripheral artery disease, and then people who've had a wound and are in remission.
Before you go on with that, I'd like to make a comment on that. First of all, welcome to the diabetic foot family. You're part of the family now, and now that you've demonstrated this interest in this, go back and be an advocate for this in your own community. That's the next step.
I think our colleague from North Carolina already sat down. I'm one of the toe guys.
Thank you. And you're a member too.
No, but you're like a GP by proxy, and on his behalf, welcome to the family. And you're not going to escape. This is a Tosa Nostra. It's like the mafia, but for toes.
But if I may add a small thing, I think to answer your question also, use a risk score like the Wi-Fi or another system, and then say, okay, if this patient is on the left side of the scoring system, very low risk of amputation, you could do it. But on the other hand, if you have a higher score in whatever system, refer.
And Dr. Petrova, who gets referred into King's? And how does that happen? And then when do they leave, or do they never leave?
Thank you for the question. Yes, possibly Diabetic Foot Clinic has one of the longest experience. It was one of the first multidisciplinary foot clinic which started. And we're very proud we have an open access referral system, and a lot of other GPs or podiatrists or nurses, they can phone us, and we would really try and offer the patients the earliest available appointment. And we do believe in that time is tissue, therefore referrals are very, very important.
Dr. Meyer, I saw that slide of that stadium going down, and I wondered, was the football team in it when it went down? Oh, okay.
No.
What happens in Philadelphia?
Well, unfortunately, in Philadelphia, still a lot of it is just reactionary. We try very hard. We do a lot of outreach to get people to come in. We have a big foot and ankle institute in Philadelphia. And for the most part, we do pretty good. But like I said, I was on call last week, and I'm still consistently amazed at how often a patient will come into the emergency room that has had diabetes for years, has never seen a foot doctor, and they've had a blown-out infection. And I'm talking, the first talk with a foot doctor is about where I'm going to amputate their foot and kind of at what level. So much of it is still reactionary, and I don't know. Sometimes I feel like we're doing good. Sometimes I feel like we still have so much more to go. I wish I could reach those patients more often.
Question?
Yes, first of all, I'm so happy to be back and to see all of you again. It's a real privilege to be here and to listen to you and to usurp all of your knowledge, if that's possible. But my question is to Dr. Andy Meyer. You mentioned that one of the criteria for surgical intervention is that the BMI should be not greater than 40. I'd like someone to enlarge upon that, the effect of the BMI on the healing process.
Enlarge upon that. That's terrific.
Yeah, you're
could
right.
Someone,
those are certainly my kind of personal criteria, and that's not for any surgery, but if I'm thinking about a formal reconstructive surgery of the foot and ankle, it's not that I don't do it, but I certainly will hesitate with that. I don't know that I'll give you my kind of full views on it, because I don't want you to think I'm completely crazy, but I just think that it's different, to be perfectly honest about it. Once you are not just obese, but you're morbidly obese, I think that the anatomy changes. We were made, our bones, and there's so much structure and function in the foot with the way the bones and joints or tendons are set up. It was made to carry a certain amount of weight. And when you're adding literally hundreds of pounds to that area, I think that the structure and function changes.
So let's continue to develop that. And by the way, Andy, there's no way you wouldn't have a practice, whether in Philadelphia or anywhere else. Come on, if you couldn't, I mean, you can't pick and choose the folks
right.
that walk or
The average BMI in my clinic is 32, or between 32 and 33. So the average patient that I see is obese.
And the rest may go to Dr. Goodney, which is the next question. So taking a broad view nationwide, is there in the United States, that is, have you seen a kind of an obesity belt, health disparities correlation, and how do you kind of tease that out? Can you develop that just for a moment?
Thanks very much for the question.
I wanted to ask you, this is a follow-up question.
Can we just let's answer this question. You could follow up just in a moment, sir, and that's terrific, because that was a superb question.
It has to do with that. Since we're interested in the BMI, do you propose that preoperatively that you try to reduce the weight and to lower the BMI before surgery, or is this possible? What is the correlation between obesity and diabetes?
Oh, Dr. Goodney, that's like this is like
the real question is, Phil, do they need a pedal bypass or a gastric bypass?
Ooh.
Well,
wow.
I've done both.
I've
done both of those operations, more of the pedals lately, but not too many gastric bypasses in recent years. But I mean, many of those comorbidities, as we all know, often are collinear. So trying to find the independent effects, because often it's those very patients that we describe. They're have poor access to care. Their BMI is a bajillion. They're still smoking. They're taking poor care of their diabetes. It's all a bad way to put the problem together. And and I certainly congratulate Dr. Meyer on his calling a spade, if you will, on the difficulty of addressing those problems. We struggle to know when to draw the line, and certainly it's good to take a stand.
But following up on that, on this teasing this out, Grant Skrepnik, some of the data that both of you showed, I mean, you were really like Bobbsey twins there. Just one of you showed a little bit more hope than the other. But you being the pessimistic one, you saw some real divides, not only based maybe on BMI or based on some of the other comorbidities like ethnicity, but you also saw a rural versus metro. Can you sort of speak to that? Is there a divide there, just like there is a size divide, or maybe a divide based on color of your skin?
Well, again, those findings indicated that regions below about 50,000 individuals in a specific city, this is controlling, again, for other comorbid conditions, heart failure, and other diabetic complications as well. It absolutely did indicate that there was a higher incidence and prevalence of amputations. One of the things that I actually, and these questions are extremely relevant, that we are often seeing, particularly in the cancer, surgical oncology area, the aspect of prehabilitation. And I'm wondering to what extent that we're going to begin endorsing prehab for the diabetic foot.
Oh, that's a superb question.
I'd like to pose a question. Just regarding these geographic differences that Phil alluded to and other people, some of the papers had 5% chronic renal failure, some 10, some as much as 40, like you have in Tucson. It's rather low. How do you explain the rather low number of patients that come with diabetic foot ulcers, Dr. Piagisi, in Italy in your series? It seems to be one of the lower series, as in London. So, can you shed some light on this geographic difference that you see in Italy versus other parts of Europe?
We don't really have a scientific explanation to that. But the problem is that pathology is ever changing. And what we are, from my point of view now, looking at is not the same cohort of patients that, for instance, we start following 20 years ago. Because we are starting following patients, then we have new patients, recurring patients, aging recurring patients. So it's really difficult to draw some line somewhere and say, well, we are here, and the epidemiology of the complication is this one. Because we start seeing, and we count, starting from the lesions, from the foot, which is actually the end of a long process, and we should reverse the point of view in my opinion, and considering the foot as a clinical part of a more complex issue.
Sir, you've been so patient.
Thank you. I'm Dave Griffin, podiatrist from Vancouver, Washington.
It's a pleasure.
The Great Northwest. It's nice to see sunshine again. I wanted to ask the panel, particularly the international experts, so with the economic disparities that exist in the world, I'm not surprised that there's 15,000 podiatrists in the United States and many areas of the country or world that lack podiatrists. How do you think we should address that problem?
Professor, do you want to, were you chiming in, or I was going to ask Luke this and Jin Yun as well.
This is a real challenge, but the first thing we in China is to recognize the problem, recognize the need for specialty to be able to manage the foot ankle reconstructions, and various efforts are put in to kind of redistribute and reorganize available resources together into create a group specialist that can carry on the equivalent function of podiatrist. And that has been done in Shanghai. And in some other centers, the function was carried out by general surgery and plastic surgery and orthopedic surgery. Yeah, I mean, envisioning in the future, there might be a possibility of training a new generation of surgeons who has a passion for limb salvage and who has a combined skill of or overlapping skill of podiatry and vascular surgery. I mean, really the line of specialty is less distinct. And that's what we're hoping as a solution to the problems.
So just like you heard, I mean, passion first, and then the skill sets second, but maybe generate a new generation of specialists in the area, depending on need. I think that's really very well done.
I think, David, at this point, even though we have
you know
many
what,
more
we're
interesting
going
questions,
to be okay.
I think you think we're okay?
Yeah, we're going to be fine.
Okay, because
there's so many
Larry
questions.
Harkless there, and I think Larry's going to want to talk to us someday
about why say it in 2 words when you could say it in 200? Dr. Slepian, you've been sitting there. Is there some big words of wisdom, Nobel worthy?
My question has to do with doing things earlier, predicting those patients. In full disclosure, I'm a cardiologist. It's the first time I've been at this meeting, but I think it's great. I'm a flow guy, but starting a little higher up. So the issue is, from my perspective, we in cardiology are always looking earlier. We have these New York Heart Association stages and then classes. And what we've now done in the AHA is come up with stages which are predictors. So I sort of like your comment someone made on the panel of prehabilitation. What are the key factors that you think we could look at, besides what you've got in Wi-Fi and your other risk scores, that maybe we haven't thought about totally, that we might want to think about, pull out, and these could be from the full range, from symptom to sign to physical finding to biomarkers to other things that maybe would be able to predict who needs to be intervened on even before we start to have the early breakdown, like all the nice composite slide you showed us from London of all the different things. I want to deal with stage 1 and 0, so you don't have to deal with things that are so far advanced.
To that end, do you think, Jorge, do you believe that perhaps we can now move forward? And you had a beautiful slide that maybe showed some of these things, looking for sort of markers to help guide us earlier, sort of theranostics, so that we can deliver maybe that cytokine at the right time and, frankly, the right place, so it's not wasted and we don't have these failures.
Thank you for your question. I think this is extremely important and perhaps a futuristic point of view for the delivery of drugs and the characterization of the process of healing of diabetic foot ulcers. To my understanding, the pioneer work in this respect was conducted by Harold Brand in the Hospital for Special Surgeries in New York, and was published in 2004 in American Journal of Pathology, so that they took the DNA from the derived material and made a sort of a transcriptome program, and this conducted the way in which the clinician or the surgeon should practice the debridement. The point is that all these studies have indicated that there is a time frame for the use of growth factors in order to keep the cells alive and to prevent the cells to lose the way and to lose the polarization in the proper way for migration and proliferation. And the other point is that all what we have done so far is the simple use of a growth factor in order to enhance the healing process. But the point is that we do not have a bulk, a sudden delivery of growth factors. So what we need is a slow release system which could fully replicate the way we have.
So not only theranostics and diagnostics, but delivery as well. And I think that's sort of your 30,000-foot view. Dr. Slepian,
to finish the comment, I think what I was getting at is prognosis. I think the opportunity, I'll throw the challenge out for you, maybe we'll work on it over the year. Everyone from their own domain, whether it's a cell person, a surgeon, a internist, an economist, we should pick one or two variables, and then we can use big data strategies to come up with models that would then allow us to maybe tease out things that are even earlier than the obvious clinical things that we're all working on. There's the concept.
Superb. It really is. You have the honor of the final question.
Well, this is interesting. I'm a clinical pharmacologist, cardiovascular specialist, and this is my first time at the meeting, so it was a nice segue. But ni hao, da nan bu su ni yu hao fu. So I'm a study of China, and I'm very surprised that there wasn't a huge gasp that a third of the U.S. population has diabetes in a continent that's a strategic partner and a trading partner of ours for sure. For the last several 100,000 years, you're a rabbit or a saber-toothed tiger. You eat lettuce or meat. Why is the weapon of mass destruction in China Kentucky Fried Chicken and McDonald's and Papa John's? And why aren't we looking at more of the preventative processes in that country to prevent this massive epidemic that has occurred? And the second follow-on about some of the theranostics and predictors of infection to surgery. 30 years ago, I worked in started a nutrition consult service. Why aren't we looking at visceral proteins like albumin and transferrin and skin fold thickness and BMI as a predictor of massive infective liability post-surgery? You can prevent many of those things by doing preemptive, pre-surgical nutritional service to these patients.
In addition to the question directly to China, let's move it to all of that massive continent and Asia as well. Let's talk about Russia and Irina. McDonald's and Pepsi. I remember when Pepsi started, still in the Soviet Union, have existed now in Russia and in this for forever. How have you been battling this? And perhaps are there any suggestions you can give to your colleagues, not only here in the U.S., but maybe a little bit east of you in China?
Well, of course, we love Pepsi. So we all, like your people, we love sweeteners, we love sugar, we love love, we love life. Yeah. So I think that, of course, we have a lot of obesity. So the same problem is all over the world. We have the same. We have type 2 children now in Russia. Also, not so many as in States, but as in Russia too. How should we fight with that? Yes, how should we fight with that? It's very difficult, of course, and particularly as we not so heavy, we are not so healthy, I think. So in nowadays, I think it's much difficult to persuade people to lose weight. But we have bariatric surgery, and we have a lot of food it's possible to lose. So we try to educate, and that's why I think Professor Bolton come to explain about the
about the possibilities to improve the situation in the world.
Professor Bolton, you want to bring us home?
Maybe.
One observation.
Andrew, can I give you the last word? But there was an observation this morning on the radio. Here in Los Angeles, 7 years ago, the city council put forward a proposal that in the poorest districts of southwest Los Angeles, you could not open up a fast food restaurant. So there was a moratorium on McDonald's and Carl's Jr. and all those places with an eye towards decreasing the cost of health care and obesity. And the result of this 7-year experience is that the BMI has gone up 10% in the last 7 years. So it's not an easy social experiment to conduct.
That's the point I was making. I was recently in Cuba, as our friend here knows, and my observation there is that they were complaining about the American embargo. I said, you should thank them. You've got no fast food outlets, no McDonald's, nothing. And the few cars, and people walk more. And the prevalence of diabetes is relatively low compared with other Caribbean islands. So that's just an observation. When you don't have all these outlets, and you don't have cars, people walk, and you have a lower diabetes prevalence. Sadly, now it's going to probably go up.
So I think we're going to have to shut this one down. I think we've gotten to all of you, and I'm sorry to Kat, and I'm sorry to Professor Harkless, but we'll take your questions at another time. This has been a superb morning, and I want to thank the assembled brilliance here to my left, to George's right. It's just been great. Now, for your gustatory delight, as I understand it, there are very nice, it's not McDonald's, not Jack in the Box, not even In-N-Out, but we have superb Wolfgang Puck catered lunch in boxes, and they're all yours. Bon appetit, and we'll see you back in here talking about the latest and greatest in negative pressure wound therapy. Cheers. Let's go with maybe 5-10 minutes.